the previous video, we used Kaplan-Meier curves to compare survival between groups. And however, oftentimes we are interested in understanding how multiple variables influence survival simultaneously. Kaplan-Meier curves are useful for comparing survival between groups, but they are limited when we want to consider multiple factors at the same time. This is where the Cox regression model comes in. It allows us to assess several predictors simultaneously and estimate their effects using hazard ratios. In this context, a hazard refers to the instantaneous risk of an event occurring at a given time. It is important to note that this is not a probability, but rather a rate of occurrence over time. Now, let's walk through how to run Cox regression models in R. In the previous video, we explored Kaplan-Meier curves to describe survival over time. Now we're going a step further by introducing the Cox Proportional Hazards Model, which allows us to examine how multiple factors simultaneously influence survival outcomes. This is especially important in public health, where outcomes are rarely driven by a single variable. We begin by loading the required packages. As mentioned before, I already have these installed on my computer, so I'm simply loading them into the session. The survival package provides the core tools for both Kaplan-Meier and Cox models, while ggplot2 will help with visualization. I'm also suppressing warnings to keep the output clean for demonstration purposes. Next, we load the same lung cancer dataset we used previously. To stay consistent, we again inspect the structure of the data, look at the first few rows, and review summary statistics. This step helps us reconnect with the dataset and ensures we understand the variables we'll be using in the model. Now that the dataset is loaded, we take a closer look and very briefly discuss its structure and contents. It includes 228 observations, each representing a patient, and 10 variables, which is typical for clinical and public health data. Key variables include time, which measures survival in days, and status, which indicates whether the event occurred, with 2 representing death and 1 indicating censoring. We also have demographic and clinical variables such as age and sex, along with performance measures like ECOG and Karnofsky scores, which reflect patients' functional status and are important for understanding survival differences. Additional variables such as meal calories and weight loss provide insight into nutritional status, though some missing values are present, as is common in real-world datasets. Finally, viewing the first few rows allows us to quickly check that the data appears consistent and reasonable before proceeding with analysis. We also do a quick recap of the summary statistics. The summary statistics provide a quick overview of how each variable is distributed in the dataset. We see that survival time varies widely, from just a few days to over 1,000, with a higher mean than median, indicating a right-skewed distribution, where a few patients live much longer than others. The status variable suggests that most patients experience the event, death, rather than being censored. Patients are generally in their early 60s, with age fairly evenly distributed, and the sample appears to include more males than females. Clinical indicators such as ECOG and Karnofsky scores show that most patients have moderate functional ability, though some impairment is common. Nutritional variables like calorie intake and weight loss vary considerably, reflecting differences in patient health, but also contain notable missing data. Overall, the dataset represents a moderately aged population with varied health status and survival outcomes, highlighting both clinical diversity and the presence of missing values that should be considered in further analysis. Moving into data preparation, we recreate the event variable. As before, the dataset codes status as 1 for censored and 2 for death. So we recode this into a binary variable where 1 indicates the event occurred. This is essential for survival analysis. We also convert the sex variable into a factor with meaningful labels, male and female, so that our model outputs are easier to interpret. Then we select a subset of relevant variables: survival time, event status, age, sex, and ECOG performance status. We include ECOG performance status because it's a strong and widely used clinical predictor of survival. While the dataset contains other similar measures, we avoid including all of them to prevent redundancy and ensure a more stable and interpretable model. We also remove any rows with missing values to ensure a clean dataset for modeling. We then perform a minimal exploratory check looking at the distribution of sex and event status. At this stage, we're mainly verifying that the data looks reasonable before fitting the model. Here we're looking at the distribution of key variables in our cleaned dataset. First, for sex, we can see that there are 137 males and 90 females. This tells us that our sample is somewhat male-dominated, which is important to keep in mind when interpreting results. And next, looking at the event variable, we have 164 events, meaning deaths, and 63 censored observations. This indicates that the majority of patients experienced the event during the study period. This is important for the Cox model because having a sufficient number of observed events, here deaths, allows us to estimate hazard ratios more reliably and draw more meaningful conclusions about risk factors. Next, we create the survival object using the serve function. This combines the time to event data with the event indicator into a format that R can use for survival modeling. This step is the foundation for both Kaplan-Meier and Cox models. Now we fit the Cox Proportional Hazards Model. Unlike Kaplan-Meier curves, which are descriptive, the Cox model allows us to quantify the effect of multiple variables on the hazard or risk of death. In this case, we're examining how age, sex, and ECOG performance status influence survival among lung cancer patients. We then look at the model summary. The key outputs here are the hazard ratios, which tell us how the risk of death changes with each variable. For example, a hazard ratio greater than 1 indicates increased risk, while a value less than 1 suggests a protective effect. This is particularly useful in public health for identifying risk factors and informing interventions. Now let's take a closer look at the results of our Cox Proportional Hazards Model and unpack what they mean. Starting at the top, we see that our model includes 227 patients with 164 observed events. As mentioned earlier, having a substantial number of events is important because the Cox model relies on these events to estimate hazard ratios reliably. Now let's move to the main results table. The key columns to focus on are the coefficients, the exponentiated coefficients, or hazard ratios, and the p-values. Beginning with age, we see a hazard ratio of about 1.01. This suggests that with each additional year of age, the risk of death increases by roughly 1%. However, the p-value is 0.23, which means this effect is not statistically significant. In other words, in this dataset, age does not appear to be a strong independent predictor of survival when we account for other variables. Next, looking at sex, specifically females compared to males, we see a hazard ratio of approximately 0.58. This is less than 1, which indicates a protective effect. In practical terms, female patients have about a 42% lower risk of death compared to males. The p-value here is highly significant, which suggests that this difference is unlikely to be due to chance. From a public health perspective, this could point to important biological or behavioral differences that influence survival outcomes. Now, turning to ECOG performance status, we see a hazard ratio of about 1.59. This means that for each 1 unit increase in ECOG score, indicating worse functional status, the risk of death increases by approximately 59%. This is a strong and statistically significant effect. Clinically and in public health, this makes sense as patients with poor functional status tend to have worse outcomes. Looking at the confidence intervals, we can further assess the precision of these estimates. For age, the interval includes 1, which aligns with the non-significant result. In contrast, for both sex and ECOG, the confidence intervals do not include 1, reinforcing that these are meaningful predictors of survival. Next, we examine the overall model performance. The concordance statistic is about 0.64, which indicates moderate predictive ability. This means the model can reasonably distinguish between patients with higher and lower risk, though there is still room for improvement. Finally, we look at the global tests, the likelihood ratio test, WOLD test, and SCORE test. All three are highly significant with p-values less than 0.001. This tells us that taken together, the variables in our model significantly improve our ability to predict survival compared to a model with no predictors. Overall, these results show that while age may not be a strong predictor in this context, sex and functional status, particularly ECOG score, play a critical role in determining survival outcomes. This highlights the importance of considering both demographic and clinical factors when assessing risk in public health and clinical research. To make these results easier to interpret, we visualize them using a forest plot. This provides a clear graphical representation of the hazard ratios and their confidence intervals, allowing us to quickly compare the impact of each variable. Now let's interpret this forest plot, which visually summarizes the results of our Cox Proportional Hazards Model. Each row represents one of the variables in our model, and the key element to focus on is the hazard ratio shown by the square, along with its confidence interval represented by the horizontal line. Starting with age, we see a hazard ratio of about 1.01 with a confidence interval that crosses 1. This tells us that age has a very small effect on the risk of death, and importantly, it is not statistically significant. In practical terms, this means that once we account for other factors like sex and functional status, age alone does not strongly predict survival in this dataset. Next, we look at sex. Here, males are used as the reference group. For females, the hazard ratio is approximately 0.58, and the entire confidence interval lies below 1. This indicates a statistically significant protective effect. In other words, female patients have a substantially lower risk of death compared to males, about 42% lower. From a public health perspective, this could reflect differences in biology, health behaviors, or access to care. Finally, we examine ECOG performance status. The hazard ratio is about 1.59 and the confidence interval lies entirely above 1. This indicates a strong and statistically significant increase in risk. Specifically, for each 1 unit increase in ECOG score, meaning worse functional status, the risk of death increases by roughly 59%. This is a clinically meaningful finding and highlights how functional health status is a key predictor of survival. The vertical line at 1 represents no effect, so any variable whose confidence interval crosses this line is not statistically significant, while those entirely above or below it are considered significant predictors. At the bottom of the plot, we also see the global p-value from the log rank test, which is highly significant. This tells us that, overall, the model provides a meaningful explanation of differences in survival. In summary, this plot makes it clear that while age does not play a major role in this model, sex and especially functional status are strong predictors of survival. This reinforces an important public health message. Beyond demographics, a patient's overall health and functional ability can have a major impact on outcomes. Next, we check an important assumption of the Cox model, the proportional hazards assumption. This assumes that the effect of each variable on the hazard is constant over time. We test this using statistical tests and Schoenfeld residual plots. If this assumption is violated, the model may not be appropriate. So this step is critical for ensuring valid results. Now we're checking one of the key assumptions of the Cox Proportional Hazards Model, the proportional hazards assumption. This assumption means that the effect of each predictor on the risk of death remains constant over time. To test this, we use the Schoenfeld residual-based test. Looking at the results, we focus on the p-values for each variable. For age, the p-value is 0.66. For sex, it's 0.13. And for ECOG performance status, it's 0.15. All of these are greater than 0.05, which means we do not have evidence to suggest that the proportional hazards assumption is violated for any of these variables. We also look at the global test, which evaluates the model as a whole. The p-value here is 0.22, again greater than 0.05. This indicates that overall the proportional hazards assumption holds for the model. In practical terms, this means our Cox model is appropriate, and we can trust that the estimated hazard ratios are consistent over time. This is an important step in survival analysis because if this assumption were violated, we would need to consider alternative modeling approaches. It's always a good idea to combine statistical tests with visual inspection to ensure our model assumptions are valid. There are 3 plots here. In the first plot, we examine the effect of age over time. The second plot shows the effect of sex over time, and the third plot shows the effect of performance status over time. But to save time, we will go through only the first one so that you can get the core idea of how to interpret these plots. In the first plot, we examine the effect of age over time. The solid line represents the estimated coefficient for age as it varies across time, while the dashed lines represent the confidence intervals. Ideally, for the proportional hazards assumption to hold, this line should be approximately flat, indicating that the effect of age on the hazard does not change over time. In this case, we observe some fluctuation in the curve, but it remains relatively close to 0 without a strong systematic trend. This suggests that the proportional hazards assumption for age is reasonably satisfied, although minor deviations may exist. The interpretation of the second and third plots follows the same principle as the first. We are again looking for a relatively flat line over time, which would indicate that the effect of each variable remains constant. In both cases, although there are minor fluctuations, there is no clear systematic trend and the lines remain reasonably stable. This is consistent with the statistical test results, suggesting that the proportional hazards assumption is not violated for these variables. Finally, we generate adjusted survival curves based on the Cox model. These curves show survival probabilities while accounting for multiple variables at once, providing a more realistic picture of patient outcomes compared to unadjusted Kaplan-Meier curves. Now, let's take a look at the adjusted survival curve generated from our Cox Proportional Hazards Model. On the x-axis, we have time in days, and on the y-axis, we have the probability of survival. This curve shows how the probability of surviving changes over time after adjusting for the variables included in our model, age, sex, and ECOG performance status. The red line represents the estimated survival probability for the population, while the shaded gray area around it shows the confidence interval. This gives us a sense of the uncertainty around our estimates. At the beginning, survival probability starts at 1, meaning all patients are alive at time 0. As time progresses, the curve steadily declines, reflecting the occurrence of events, in this case deaths, over time. You'll also notice small tick marks along the curve. These represent censored observations, meaning patients who were either lost to follow-up or did not experience the event by the end of the study. One important thing to note is that this curve is adjusted, meaning it accounts for the combined effects of age, sex, and functional status. This makes it more informative than a simple Kaplan-Meier curve because it reflects survival while controlling for these key factors. From a public health perspective, this type of curve helps us understand the overall survival pattern in a population while accounting for important risk factors, which can be critical for planning interventions and allocating healthcare resources. We see a gradual decline in survival over time with a steeper drop in the earlier period and a leveling off as time goes on, indicating fewer events occurring among those who survive longer. This approach allows us to move from simply describing survival patterns to actually understanding the factors that drive them, which is a key goal in public health research and decision making. We have now come to the end of today's lesson. In this video, we introduced the Cox Proportional Hazards Model and learned how to analyze the effects of multiple variables on survival over time. We also explored how to interpret hazard ratios and assess model assumptions. The Cox model is one of the most powerful tools in epidemiology and clinical research, as it helps move beyond description and towards identifying important predictors of health outcomes. In the next video, we will build on this foundation by exploring mixed effects models, which allow us to analyze clustered or hierarchical data, such as patients within hospitals or regions.